Hello, this lesson is about cholera. Cholera is a dehydrating diarrheal disease that rapidly leads to death in the absence of immediate initiation of appropriate treatment. Worldwide, 1.3 billion people are at risk for cholera, resulting in an estimated 1 to 4 million cases and 95,000 deaths annually. Cholera is now endemic in many countries, specifically in third world. Cholera is caused by Vibrio cholera, which is a gram-negative coma-shaped bacillus, subdivided into subgroups by its somatic antigen. Of the more than 200 serogroups, only serogroups 1 and 139 have been associated with epidemics. Humans are the only known host for Vibrio cholera. The organism thrives best in moderately salty water, but it can survive in rivers and fresh water if nutrient levels are high, as occurs when there is organic pollution such as human feces. Consumption of contaminated water and ingestion of undercooked shellfish are the main modes of transmission. Consumption of contaminated water mainly in developing countries, whereas ingestion of undercooked shellfish in developed countries are the main modes of transmission. In cholera endemic areas, the incidence is highest among children less than 2-year-old. However, in epidemics, all age groups are usually affected. Persons with blood group O, decreased gastric acidity, malnutrition, immunocompromised states, and absence of local intestinal immunity, mainly by prior exposure by infection or vaccination, are at increased risk for developing severe disease. Household contacts of cholera-infected patients are at high risk for this disease because stools of infected patients contain high concentration of Vibrio cholera. Moreover, as Vibrio cholera organisms are shed, they enter into hyperinfective state, requiring an infectious dose that's reduced by 1/10 to 100 compared to organisms that were not shared by humans. As I've said, humans are the only known hosts for Vibrio cholera, so natural infection with cholera occurs only in humans. When bacteria are consumed with food, few organisms, as much as 10 to the power of 2 to 10 to the power of 4 organisms are adequate to cause an attack because of the buffering capacity of the food. Any medication or condition that decreases stomach acidity makes a person more susceptible to infection with Vibrio cholera. In humans, Vibrio enter orally through contaminated water or food. Then the ingested pathogen passes through the acidic barrier of the stomach and they multiply in the small intestine. In the small intestine, the Vibrio penetrates the mucosal barrier and they adhere to the microvilli of the epithelial cells and they multiply there. The Vibrio strictly epipathogen and they do not penetrate deep into the guts and there is no bacteremia. So cholera doesn't cause sepsis because it doesn't penetrate the gut. So there is no bacteremia. The virulence of Vibrio cholera is due to cholera toxin. The toxin also inhibits intestinal absorption of sodium and chloride. When we came to clinical manifestation, most cases of cholera are mild or inapparent. Among symptomatic individuals, approximately 20% develop severe dehydration that can rapidly lead to death if not treated. Following an incubation period of 1 to 3 days, acute watery diarrhea and vomiting ensue. Diarrhea can progress to painless purging of profuse rice water stools. The stools of cholera patients look like a water in which rice is boiled. This is due to suspended flakes of mucosa with a fishy smell, which is a hallmark of the disease. Vomiting with clear water fluid is usually present at the onset of the disease. Cholera gravis. This is the most severe form of disease, resulting with purging rates of up to 1 liter per hour of fluid or diarrhea. This purging leads to dehydration manifested by decreased urinary output, sunken fontanelle, sunken eyes, absence of tears, dry tongue and oral mucosa, and poor skin turgor, 3D pulse, tachycardia, hypotension, vascular collapse, and also washerwoman's hand, which is shriveled hands and feet. Patients with metabolic acidosis can present with typical Kussmaul's breathing. If fluid levels are not rapidly corrected, death can occur within hours. Regarding laboratory finding, Findings associated with dehydration such as elevated urine-specific gravity and hemoconcentration are evident. Hypoglycemia is a common finding that is caused by decreased food intake during the acute illness. So serum potassium may initially normal or even high because of the presence of metabolic acidosis. However, as the acidosis is corrected, hypokalemia may become evident. Metabolic acidosis due to bicarbonate loss is also a prominent finding in severe cholera. Stool examination reveals few or no fecal leukocytes and erythrocytes because cholera does not cause inflammation. Dark field microscopy might be used for rapid identification of typical darting motility in wet mounts of rice water stools. These findings that disappear once specific antibody against Vibrio cholera are added. Rapid diagnostic tests are currently available and may be specifically useful in areas with limited laboratory capacity. When we see the complications, delayed initiation of rehydration therapy or inadequate rehydration often leads to complications. Renal failure from prolonged hypotension can occur. Unless potassium supplementation is provided, hypokalemia can lead to nephropathy and focal myocardial necrosis. Hypoglycemia is common among children and can lead to seizure unless it is appropriately corrected. Regarding treatment depends on the severity of dehydration and the cholera cases confirmation. The first thing is rehydration. Up to 80% of patients recover with oral rehydration solution only, and 10 to 20% may need administration of IV fluids such as ringer lactate and NS. Zinc supplementation for 10 to 40 days is needed in children less than 5 years. In addition to rehydration, antibiotics is also needed. We can give either tetracycline for 3 days or erythromycin for 3 days. Improved personal hygiene, access to clean water, and sanitation are the mainstay of cholera control and prevention. Appropriate case management substantially decrease case fatality rates. In 2011, the World Health Assembly recommended the use of oral cholera vaccine to complement existing water, sanitation, and hygiene initiatives for cholera control. Oral cholera vaccines are safe, they are protective for approximately 2 to 5 years, and they confer moderate herd protection. This is all about cholera. Thank you for listening.